It is the top of the hour, so we will go ahead and get started. Welcome, everyone, and thank you for joining us today. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have just a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have an opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, but we will wait to answer questions until the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference. So I will send a link out after this once that has been posted. A survey link to an evaluation form will be included in the chat toward the end of the webinar and in the follow-up email you will receive afterwards. We would very much appreciate your feedback. So let's get started. I'd like to introduce Dr. Preeti Uram, Chair of the Forum's Medical Advisory Council, who has some introductory remarks.
All right, good afternoon, everyone. Thank you all for joining. So we will be kicking off the Don Maloney lecture series. Kelly, if you can share the screen.
There you go.
Okay, so this is our introductory lecture for today as part of the Don Maloney Dialysis Leadership Medical Director Series. Dr. Donald Maloney has been a member of the forum, has served the forum for a number of years. So this lecture series has been named in his honor. And we have a whole slew of lectures that is very useful for the early nephrology physician in their career, the fellows. It can also be a very useful tool for dialysis unit staff. And we are hoping that this will have a wide reach. These will be recorded and made available for everyone for later use as well. But we are really happy to see so many of you join because we will be taking live questions. And with that, let's move on to the next slide, Kelly. So this is the schedule. The lectures are scheduled at various times, so that makes it kind of difficult for us to send reminders or like have them added to the calendar. So we understand that this is not ideal, but these lectures are really of great value. So we hope that you are able to register for these lectures individually. I think Kelly is trying to send out reminders for everyone that has registered, so you can add them to your calendar, but you have to physically add them to the calendar. So, so just something to keep in mind. Next slide. And we also have a whole forum session that's dedicated to regulatory landscapes, so medical directorship and administrative issues in the dialysis units at the upcoming annual dialysis conference. So this will be in Kansas City from Feb 26th to March 1st. So we hope if you are able to attend, please do so. The forum sessions will be actually on Saturday. That's listed on the next slide. So we have a really great lineup for this. So this will be on Saturday, February 28th at ADC 2026. This will be in Kansas City. The registration link is going to be in the slide deck, which you will have access to as well. And with that, I have the distinct pleasure of introducing Dr. Andrew Howard. Dr. Howard is a retired nephrologist, having practiced for over 30 years with the Metropolitan Nephrology Associates in Northern Virginia and Southern Maryland. He is the chair of the Kidney Transplant Collaborative currently. He is a former president of the forum, remains an ad hoc member of its board of directors, and remains very, very active with the forum. He knows the ESRD PPS like the back of his hand. He's our go-to expert for anything related to value-based care, PPS. He routinely helps us write comments for the proposed rules that come out of CMS. So we are very grateful for his ongoing work with the forum, and there's no better person to talk about the history of ESRD, the ABCs of PPS. So welcome, Dr. Howard.
Thank you very much, Preeti. Kelly, will I be able to advance or should I just work through you? I'm happy to do either.
It's completely up to you. I've got the
Okay.
slides up, so I'm happy to advance for you, but if you want to share your screen, you can do that too.
Okay, yeah, that may actually work out. Let me go ahead and just try to do that if I could. Let's see here. Hmm, I don't know here.
It's just a few slides down, is the start.
Slide number
Yeah,
6, Sandy.
maybe I'll have you just, I thought I had clicked on that. Are you all?
We can see your screen. I think you just need to go
Oh,
into
great. Okay, I
slide
think I have it
presentation mode.
now.
Yep.
Wonderful.
Yep.
Great. Yeah, it just may be a little easier if I
Of
go
Yeah,
through
there
course.
you go.
this. So
Yep.
wonderful.
Perfect.
So thank you again, Preeti. My disclosures are listed here. I still continue to help my group through the kidney care choices models, um, and other roles, as Preeti had mentioned. What I would like to do today is give you all a understanding of how did the PPS and QIP develop? Really, what's the history of this amazing ESRD benefit that really, as you'll see, almost never happened. Some consider it an accident. It's probably the only chronic disease this will ever happen for, and we'll quickly walk through that. It's a fascinating history. I'll give you some vignettes from history. We'll talk about how the PPS is derived, the math behind it, simply high level, the current measures and weights, and I'll show you the modification. It's amazing over the years of the program what's happened. And finally, and perhaps most importantly, how does a facility get penalized and how do you avoid getting penalized? Let's talk about the history. It really, dialysis, you have to go back to Thomas Graham in Scotland to the mid 1800s when the concept of dialysis first came about. I really would be remiss if I didn't mention George Haas, a German physician who really experimented with dialysis post World War One. Unfortunately, he finally gave up. He just couldn't get it to work. And really, it was Willem Kolff, a Dutch physician in the middle of World War II, that really developed a functioning dialysis machine that was referred to as the rotating drum. He's the first of the big four. It took 16 failures, but on his 17th try, a lady with acute kidney injury did survive. And of course, dialysis, there was no permanent access. So it was only acute kidney injury. It had to be short term. Fortunately for the US, he visited the United States in 1947. That's why I have that date there. And he brought a few of his machines with him. And he formed a partnership really with John Merrill at the Brigham in Boston. John Merrill really led the Brigham to become the first preeminent kidney transplant center. The modifications, the so-called Kolff-Brigham device, was used extensively in the Korean War, and it showed successfully it could treat acute kidney injury. And then on December 23rd, 1954, the first successful kidney transplant really occurred at the Brigham. This was between two identical twins, two young men. And we didn't understand anything of really the immune system at that point in time. I often joke when I was in med school in the 70s, I think our whole immunology was one day. But it was exciting. I had to learn it during my fellowship as things were exploding. There really wasn't transplant immunosuppression in 1954. Yes, steroids had been developed. The Nobel Prize had been awarded in 1950, but they really weren't being used. 6-mercaptopurine was being developed, but it wasn't used for transplant. And it was really azathioprine that came out of that. And then it really was in the 1960s that we saw azathioprine and steroids starting to be used. So back in 1954, what they did is they exchanged skin grafts between the two brothers and they thought, aha, they truly must be identical. And the transplant was performed and it worked. And I had the privilege of being at the American Society of Transplant at the 40th anniversary meeting up in Boston. And the donor was actually brought out on stage, and Dr. Murray, I believe, the surgeon, that's Joseph Murray listed there. Then, really, we had to have a way to have chronic access. So Belding Scribner led the way with Wayne Quinton, an engineer who he partnered with. And that happened really in the early 1960s, followed by the AV fistula, developed at the Bronx VA, also in the early 60s. And a gentleman, Wayne Shields, was really the first patient. He began dialysis out in Seattle in the 1960s, actually amazingly lived 11 years. But as the 60s progressed, the clinical effectiveness of both therapies really became clear. And that was critical because that set the stage for what eventually would be the United States Congress and Senate passing a benefit. So some of you may know this. Life magazine in 1962 had quite a remarkable story. It talked about the committee in Seattle, which they kept anonymous who those members were. But they really decide who would be treated and who would not. And there were several patients who were treated from this, but this is where early nephrologists, remember, the nephrology boards didn't really happen for many, many years. It wasn't until I believe 1972 when the first boards were actually. But still, there were early nephrologists, and they all made the trek to Seattle to learn how to do this. So the federal government did respond. It opened several dialysis centers at VAs, and public health, the early public health service funded 24 additional centers. Cost was a real concern at the time, and they realized even back then home dialysis was less expensive, was cheaper. And then the NIH was funding research. The USRDS came out of this through the registries, and the Gottschalk Committee, very critical, was established in 1965. I do need to mention the fourth giant in nephrology, George Schreiner, who actually practiced at Georgetown in Washington, D.C., and he was a member of the Gottschalk Committee and was instrumental with others in seeing the legislation finally enacted. And what the Gottschalk Committee did in 1967, Medicare was just 2 years old at the time. They recommended that the Medicare program should be amended, and that's how end-stage kidney disease should be covered. So many people feel this may have been the seminal event, but at a House Ways and Means Committee at the time, and it's still true today, Ways and Means in the House and Senate Finance in the Senate are two of the key bodies where health-related legislation moves. Of course, now Energy and Commerce is another body in Congress. But there was a man, Shep Glazer from New York, who was on dialysis, middle-aged kids working, and he insisted that he be dialyzed in front of Congress. They encouraged the public at that point to come in. He got a lot of pushback from the National Kidney Foundation, from George Schreiner, because they were afraid, oh my God, what if something goes wrong? That will kill this. It'll never go forward. But Shep Glazer insisted. He showed up in D.C., much to Dr. Schreiner's chagrin at the time. He contacted him and said, Dr. Schreiner, you have to deliver a machine to Congress because I intend to be dialyzed tomorrow. The National Kidney Foundation really didn't want Dr. Schreiner to go to lend their imprimatur to this at the time because they were so afraid, what if a mistake happened? So he sent one of his fellows, and according to history and what the fellow said, Shep Glazer actually, are you ready for this? Went into VTAC after 5 minutes. No one knew it, and the fellow quietly stepped in, terminated the dialysis, but Congress had seen what this was and they were amazed. And he came out of VTAC quickly and fortunately, as soon as it was terminated. And many people feel that was the terminal event that finally led Congress through the House and the Senate to extend Medicare to the disabled. And by a last minute provision, people with chronic kidney disease requiring hemodialysis or transplant, and I put the actual quote in from the legislation, shall be deemed to be disabled. The first time a chronic disease had been added, perhaps the last time, but who knows what the future holds. So this was the landscape in 1972 and July 73 when the ESRD program began. There were 10,000 patients. We now know that we have between dialysis and transplant 900,000 or more, 229 billion. I think most of you have heard the figures just for Medicare, 30 to 50 billion without commercial. So yes, the program was a wild success beyond anybody's dreams. I would be remiss, since we are representing the forum, not mentioning this, but in the ESRD amendments, some 5 years after the program began, the networks were created. There were 32 at the original time, now 18. And this was the first modification of conditions for coverage. Believe it or not, MedPAC, way back in 2001, recommended a fixed payment for an expanded bundle of ESRD services, and Dialysis Facility Compare first came out. And then the next critical piece of legislation was MIPA, Medicare Improvement of Patient and Providers Act in 2008. And I did put it in red for you so you can see. It said we want to promote patient health by providing a financial incentive, but it wasn't a positive payment, it was a takeaway. You had to make sure you performed so you didn't have 2% of your payment taken off. By the way, this was the last time that the conditions for coverage have been modified back in 2008. And star ratings were first introduced and followed for hospitals, dialysis facilities, and many others after this. So the PPS became effective some 15 years ago on January 1st, 2011. You can see in the second bullet, this is what it provided for. And the bundled payment treatment was to include drugs, laboratory services, supplies, labor, and other capital related costs. Acute kidney injury was not originally included. The strange workings of Congress through an act called the Trade Preferences Extension Act, go figure. AKI was a last minute add-on, and it was passed in 2015 to become effective January 1st, 2017. Home dialysis is a very recent add-on, and I have to credit my colleagues in the forum and really our patients. Without our Kidney Patient Advisory Council, I just don't believe this would have happened. Their comments, I think, were so instrumental, and other patient organizations, the NKF and others around the country, who really made this happen. I think Congress listened to the patients. And finally, last year, home dialysis was added. The QIP, you can see this all came about in MIPA in 2008 with some other statutes that added to it, but there are people often ask, why are these measures included? There are statutory requirements for certain measures to be included. PAMA was the last and said conditions treated with oral only drugs outcomes. And here, this is obviously bone mineral metabolism was the last to add. But the other 5 bullets are all part of MIPA. They're performance standards, a performance period, a total performance score. We're going to work our way through all this, a payment reduction, and public reporting. So this is the simple formula. Every year, last year's payment, which in 2025 was $273 and change, it increased by just under $8 this year to $281.71, just about a 3% increase. So what does this? Well, these are the adjustments to the previous year's payments. Has to be something for labor. That is you can see it below in the next bullet. That's the majority of the costs for dialysis. But every year we get new labor figures, and it's a positive adjustment. You can see a number slightly above 1. New for this year, and something the forum and many others commented on, was called the non-contiguous areas payment. It was for higher than expected non-labor costs, but it only applies to a very few facilities, those in Alaska, the Pacific Territories, Hawaii. That's really it. But it has to be budget neutral. That's why that figure is less than 1. And of course, what's been long-standing, really what's called the market basket, that's essentially what I put in the first bullet. That's the costs of all the goods and services to provide dialysis, both in center and home. What's hotly debated, every year in comments is price inflation. Many commenters have argued strenuously with CMS that the adjustments just don't keep up with inflation. Um, don't shoot me, I'm only the messenger, but it is what it is. And this is our current payment this year. Now, this is not the whole story. So this is the math. You can now understand it a little bit better. How do we get the 281.71? But there are many other adjustments. They're a patient level. You see them there. What comorbidity is there two acute adjustments and two chronic adjustments. I'll start with the chronic. Many people feel these are arcane, these need to be changed, but they haven't been now. And the chronic adjustments are hereditary hemolytic anemia or sickle cell and myelodysplastic syndrome. Those are the chronic adjustments. The acute are GI bleed with hemorrhage. And oh my gosh, I just blanked on the second, the second chronic adjustment. But there's been a lot of consternation. And then you see the others, they're facility level. And the other, I have 5 listed. I'll talk about the last 3. Training is for home training. Outlier essentially refers to higher than expected cost patient over, the expected norm. And if any of you on the watching this are involved with pediatric dialysis, they're separate pediatric adjusters. Back in 2024, they started a pretty significant, a 30% adjustment for every treatment to try to bring pediatric facilities up to speed. Unfortunately, those expire at the end of this year. So the first one I want to briefly talk about is this transitional drug add-on payment. When the PPS began, ESAs, erythrocyte stimulating agents, were the only drugs. There were multiple legislative proposals which kept extending this, extending this. It was supposed to happen 10 years ago in 2016, and finally, last year, January 1st, it started. And this is a 2-year process. Although the first drug you saw, oral cinacalcet and the injectable etacalcetide, were covered for 3 years. Korsuva is done with the TDAPA, and the first of the HIF-PHI oral anemia meds is also done. We currently have 3 that are being covered. DefenCath to prevent infection, catheter installation through this June. And then through the end of this year, the second HIF-PHI, and of course the oral phosphate binders. This is fairly big money, these, and the end of this year, they're going to be done, and it remains to be seen what's going to happen with that, whether they'll be incorporated with no adjustment, there'll be adjustment. Right now, they're saying there won't be a post-transitional drug adjustment, which was the other thing CMS agreed to add for 3 years. Right now, you can see the 3 drugs, Korsuva, currently under this, the HIF-PHI, Duvroc, and DefenCath, which will begin this summer. I always think of Dave Henner. Dave, I saw you join the call when I talk about this. They added another adjuster for new and innovative technology. You can see the rationale for it here. It was for 2 years. I must say, despite all the applications, this hasn't gotten much traction with CMS. Tableau system is the only innovation to be approved to date, and it's done. I mean, it was back in 2022, 2023. Right now, there is nothing in this category for 2026, but we'll see what happens this year. Real simple, but there's a performance year, and then the payment year actually happens 2 years after the performance year. You see the little asterisk in 2015. That was the first time that facilities actually knew what they were being penalized for. Took a while to catch up. So right now we are in the 2026 payment year. So facilities are starting to see those payment adjustments. That reflects what they did in 2024. 2025 performance years in the books. There'll be time for facilities to contest that because those payment adjustments won't happen until next year. And we are in the 2026 performance year, which will affect payment in 2028. I put a few slides in from this special open door forum, which hard to believe this was almost 15 years ago, but CMS basically got everything right then. They said they wanted achievement to be relative to some national or other appropriate benchmark, and that there should be a way a facility could improve if they couldn't achieve. There ought to be different pathways. God, my watch heard me talking and Siri jumped in. Uh, they also said that over time, outcomes and payment ought to be weighted more toward outcome, patient experience, and functional status, and that there ought to be straightforward methodology so providers, payers, and patients could make meaningful distinctions among providers. And that they said more than 30 years ago, actually, it was almost 40 years ago at that point, but they saw this as a natural evolution. You may laugh if you weren't aware of this. I happen to be looking at Don Maloney on my screen. Don, you live this with me. And of course, the first year, these were the measurements. It was two hemoglobin measures, less than 10 and greater than 12, and urea reduction rate. They did, for those of you with small, perhaps rural facilities or hospital-based, but small facilities, they did say, yes, we ought to have minimum data. So if a facility can't get to a critical number of patients, they shouldn't be scored. They should get a pass. And they established the national performance rate and an improvement rate, and they would give you whichever you did best in. So this is what things looked like actually back then. And so you added those three areas up, and something we're very familiar with now, but we use a scale of 100, not 30, but this is how payment penalties broke down. I'll never forget, I was at a meeting after the quality conference back in 2012, before this came out. And I was sitting with Dr. Patrick Conway, who ran CMMI, the Innovation Center, was also Chief Medical Officer for CMS and actually was acting administrator. And Dr. Conway said, well, Andy, what do you think? What should be the penalty rate? How many facilities you think should be penalized? I said, gosh, Dr. Conway, I don't know. And he said, well, here it is. He said, we're going to penalize 30% of facilities for about 17 million. And that was the first year. So let me just give you a quick walk through history. A lot happened. So what you'll be impressed with in the early years is they were intent on adding measures. I remember talking with Dr. Frank Maddox. Some of you may know the name. Frank was Fresenius's chief medical officer and then global head. And I remember in 2013 saying to Frank, gosh, it's gotten pretty complicated, Frank. I think we're up to about 6 to 9 measures. Little did we know. They did in 2013, they did set up what would be a performance standard, 50th percentile of performance, and also to avoid a penalty, you had to score above 15% of other facilities. If you hit 90%, you were safe. You weren't going to be penalized on that measure. You can see over the years, I highlighted another. They finally in 2014 in the rule for starting in 2015, they said, gosh, what if a environmental impact happens, a hurricane, bad snow, something that impacts a facility they have no control over. So they did establish an extraordinary circumstances exception policy. Again, you can see a lot of changes to different measures over the years, updating of measures. They started validation studies for both what was then Crown Web, EQRS in today's vernacular, and then also in NHSN, a dialysis infection, dialysis event validation studies. Finally, in 2018, they took 4 measures out, or they recommended for removal that year, and they established various factors to do that. Um, oh, I want to go back one just to show you. Transplant finally makes it in. PPPW down there at the bottom, starting in 2019, the first time a transplant measure made it in. Um, some converting of measures, and also then, of course, COVID hits. So what do they do? Well, they say for 2022, based upon 2020, we're not going to penalize any facility. There'll be no payment reductions at all. Such a dramatic event out of facilities control that was so disruptive. No facilities will get penalized. They continue that the following year in 2023 for 2021, and they suppress seven measures. But by 2024, based upon 2022, full penalties were back. Um, Critically, in 2023, they said that if a facility is able to score 50th percentile of national performance and the median of performance for reporting measures, they can avoid a penalty. They've got to do this, and I'll show you, we'll get to this. What are the biggies? Um, Then what you see in for 2024, of course, change in administrations, but a number of health equity measures and social determinant of health measures were put in. But then, as you'll see, as we move through that change of administration, new CMS and HHS leadership, those were taken out. And I'll show you what do things look like now. So really an amazing history. I know those on the forum have listened to me wax on each year and the proposed rules about these, but it's really hard to believe when you see how much has been done in the 15 years of the program. I'd be remiss if I didn't share the two frameworks again under the former administration. This is a snapshot in 2024. Health equity is the foremost pillar. But you now need to know we're operating under a different administration. So health equity has been replaced with closing gaps of care. And this is what we're operating on for last year and for 2026 and presumably going forward. Um, so this is what this payment year looks like. You can see down below, and I told you facility commitment to health equity was taken out, but the current administration and HHS CMLs felt, gosh, facilities already were told this was included in performance year 2024, so we're going to keep it in for 2026. You can see a subtle movement to equalize weights in the different domains, and I'll show you what happens as we move forward. So these penalty reductions, this is what the scale is. To avoid a penalty, a facility had to get at least 53 points on those measures out of 100. This is what the 2027 looks like. All the health equity, social determinant health measures have been taken out. That left us with three reporting measures. And you can see that in the care coordination and clinical care, almost each measure is of equal weight now. ICH caps is still the biggie. This was finalized for 2027 in the books. 2025 is done. And I show you payment year 2028, which is the year we're in. I only highlight in red ICH caps because there were several changes in that, and I'll show you what those are. So they proposed and did modify ICH caps. They said this would save about $650,000 because of less reporting requirements for facilities. They took out 23 questions. The forum and others had several comments, but I just wanted to give you a high-level look at what was taken out. So, quality of dialysis center care and operations, 4 questions, all the questions concerning kidney doctors, communication and caring, the 1 question rating kidney doctors, and then you can see the others. Again, they did respond to numerous comments, and the forum did offer several about this, but they basically adapted in the final rule what they had proposed. So this is what it now looks like. I showed this in red because this might change. We won't actually know the final payment penalties until we get to next year's final rule. We'll see the proposed rule come out, ballpark July 4th this year. That's been typically about when it comes out, end of June or just before the July 4th holiday. So this might change. Right now, you would have to score above 57 points or above not to have a penalty, but again, might change. So what do things look like? Well, for 2027, they're projecting about 22 million in payment reductions. Uh, don't think that will change for 2028, 18 million in payment reductions, a little less. So how do you avoid a penalty? Well, as I said, for the clinical measures, you need to score at or above the performance standard. We'll go over that in a minute, and I just wanted to show you here. So what are the biggies? Well, ICH caps, long-term catheter rate, standardized transfusion ratio, and the dialysis adequacy comprehensive measure, which was broken up into 4 individual areas, 2 adult, 2 pediatric. Those account for 50%. But you need to score at or above 50% in every to truly avoid, but you can really minimize your penalty if you are going to get one by at least achieving in those. For the caps, for monthly or however frequently your center holds meetings, really need to have patient participation, include patients and patient-centeredness, talk this up. There is still a minimum of 30 completed ICH caps for a facility to get scored. You don't want to forget to, all you have to do is report your data. You're not scored on outcomes for the 3 reporting measures. You just can't forget to report. And it's really a process that every month facilities or on some regular basis need to be looking at this. So for 2028, it starts now. We're already in the 2nd month of the year. Where are we? How can we improve? What do we need to do differently? So that performance standard, again, if you are scoring or look to be on track for the 50th percentile of national performance, I'll show you what those are so you don't have to search for it. You'll have it as part of this presentation, which Kelly will distribute to everyone on the call. You're at no risk of a payment penalty for that measure. So what about the reporting deadlines? Several have passed. In general, for the clinical data, it's 2 months after the month ends. So we have 3 big deadlines coming up. For March 2nd, we have the December data due. That'll be the last data for 2025. And then we have the 2 reporting measures, clinical depression and follow-up assessment. Also due March 2nd for the whole year, and ICH caps for the whole year. So these are the national performance standards for 2028. This is what is projected to occur. So here's a handy reference table for you and your facility. How am I doing? How's my facility doing in each of these areas? And you can know you're on track to avoid that penalty. The ICH caps is going to change for 2028 because I showed you what was taken out. Nephrologist is gone. This is what's left. And this is what's projected for 2028 to be 50th percentile of performance. For the 3 reporting measures, not too complicated. As many on the call know, especially my forum colleagues, wouldn't be surprised if in this year's proposed rule we may see a change in bone mineral metabolism where hypocalcemia may go away. I know I'm preaching to the choir out there, but data that phosphorus, PTH, probably better measures than hypercalcemia. We'll see. Andy Howard does not have a crystal ball. I don't pretend to understand, but I wouldn't be surprised if we see a change coming there. Again, I had mentioned for those of you with small facilities, these are the minimum number of qualifying patients, QPTS, that you have to see to get scored in each of these areas. So if you're under this, you have a free pass. You will not be scored on that measure. Just to wrap up, because I really wanted to save time for questions, I wanted to just show you the payment penalties. For 2027, this is what's projected. Unfortunately, a jump. Almost 44% of facilities are projected to receive a payment penalty of almost 22 million. What I've shown you here is independent and small are definitely going to take the brunt of this. They're the highest percentages, although some improvement from what was projected a year ago. Although those receiving the lowest penalty drops, unfortunately, those receiving a 1% and 1.5% has gone up. 2%, yeah, unfortunately, even though it's improved, that's a big jump you can see taking the biggest hit from previous years. 2028, again, this can change, but you can just see the projections a little better than 2027. Of course, the performance years in the beginning, so this might change. If you're interested, and you'll have this down below, you can see the measures that are going to determine that for 2027 and 2028. I wanted to really just finish showing you a window into the future. These were 2 requests for information in this year's rule. The forum and others did contribute. The first was about advancing digital quality measurement in the QIP, trying to make it ultimately easier for facilities to report. I picked out the 5 most common response areas that CMS did get comments from, just so you could see what these were. Clearly, this for rural, smaller facilities independent, still a significant burden. The giants, certainly DaVita, Fresenius, do have easier submission for their facilities and help with this. But again, CMS appropriately is interested in really moving to digital submission rather than manual. And next, measure concepts under consideration. These were the 4 areas they sought comments on: interoperability, well-being. I'll highlight the second bullet, measure of access to palliative care. For elderly patients, gosh darn, we're rapidly approaching that. In the nutrition category, no great surprise knowing the focus of CMS today, and we had some excellent comments from members of the forum that we did submit on this. I will point out with the third bullet, you all are living in a very exciting time with actually tools at our disposal to delay progression. And this actually is a former measure in the kidney care choices model now. This is being rated actually through use of drugs to actually delay progression. And last but not least, physical activity. Again, for Don and I, this goes back actually quite a while. I remember having the bicycle pumps in the facilities decades ago. But again, these are the 4 big areas so we'll see when this year's proposed rule comes out. We'll see what, if any, of this and this have been included in next year's proposed rule. And Preeti, that's really all I had. So I'll be happy to open it up for questions. I can stop sharing and turn it back over to Kelly so she can control things. And
yeah, thanks so much, Andy. That was a lot of background and information. The slides will be available for everyone to review. So as Andy said, so Kelly, do you know? Can you put the link in the chat perhaps for people to access whenever they become available?
Yes, what I'll do actually is I will send out an email to everyone with the slides and then the recording, and I will also have those posted both to the website so they can access those at any time.
Yeah. Okay, thank you. So I know those slides with all those different numbers, can be quite dense. So I think, one has to take time and look at those for us to clearly understand the implications and all of that. But I think we can take some questions if folks have questions. I do see one question in the chat, Andy. I think Lauren said you mentioned the ICH CAPS depression screeners. They are due for all patients end of March. Is that right?
Yes, apparently the due date for facilities to submit, will be March 2nd is what they've said now. So that's why I wanted just to highlight that because that's coming up really 3 weeks, I guess, or so. So that's why I wanted to highlight that, Preeti.
Okay. All
And
right.
again, it still is 30 responses for a facility to, fall into that category for ICH cap. So if it's less than 30 responses, facility would get a pass.
Okay. We have another question from Jayesh Shukla. NHS and BSI measure seems to be favoring underreporters since all the data is self-reported. Not sure what percentage of NHS and validation studies uncover unreported BSIs. Any suggestions to improve this measure so that there is a bit of a level playing field between healthcare system-owned dialysis units and standalone dialysis units?
No, that actually is a great question. And yes, this has been an area of intense concern. I saw, I don't know if he's still on, Dave Henner, one of our recent past presidents, has been an area of intense focus. Oh, there you are, Dave. Dave, if you don't mind, I may actually let you jump in if you wish to, because I know this has been such an area of intense focus and interest, and you've really helped us with our comments over the years. It was a great question.
Yeah, no, definitely. Thank you, and I appreciate it. Yeah, I mean, certainly, reporting is always a concern, right? Because these measures are based on how well facilities report and how honestly they report and how good data you have, for one. And number two, it's total bloodstream infections, right? It's not just access related, so that counts towards the measure. So there's a lot of scrutiny, often and rightfully so, by facilities because even the contaminant counts. You have to report that if you're reporting honestly. So if you're reporting honestly, contaminants count. Any kind of urinary tract infections, wounds, etc., things you may have no control over at the dialysis facility level. So we've commented on this year after year, but to no avail so far. But we keep trying. So yes.
And I will add to Dave, not just the forum, there have been others. This is one area, along with the standardized transfusion ratio. This is an area of intense concern that many commenters have said this is largely beyond the control of facilities. This is now, and that one is significant because that's got a significant weight. So, but again, CMS said we need an anemia measure. So it's not from lack of trying. It was a great question, and we will continue to advocate for the community and all the facilities in the country on this.
Absolutely. Thanks, Andy. Thanks, Dave. Any other questions? I believe the participants can unmute themselves and ask a question if they would like.
Yeah, while we're waiting, I can also add, if anybody's interested, I can give you a quick history of how did commercial insurance follow Medicare. It didn't happen immediately. It was an interesting history. But while we're waiting, what you know now is the Medicare secondary payer benefit. So this actually began back in 1981. It was about 8 years after, but commercial insurance didn't immediately pay for dialysis. It was set up so any beneficiary who already had employee health group program coverage, i.e. commercial, would in fact be covered. But that was in 1981. It was the Omnibus Budget Reconciliation Act. Interestingly, some of you do know that it's now 30 months that transition period occurs. It was originally set up at 18 months. It wasn't actually until the Budget Reconciliation Act of 1997 that the 30-month came in. But, here we are now, well over 25 years that's been part and parcel. And that is critical not only for dialysis, but transplant is covered as well. But that's why we're waiting, just the brief history of how did commercial fold into all this.
Thanks, Andy. Raman is asking if a facility gets a 1% penalty, does that mean that they will receive $2.5 less for each treatment if the baseline payment is $250?
Yeah, so essentially, that would be correct, Raman. 1% would in fact be deducted from every PPS payment. Correct. And again, you may think, but really, for facilities operating on the margin, particularly if there's low commercial mix, depending upon, labor costs, non-labor costs, location, it adds up. It really can be significant. So, yes, but the math is correct, Roman, as you stated.
And that affects all Medicare patients, correct?
Correct.
Yes. Andy, can you maybe briefly comment on the monthly capitation fee side of things for the physicians?
Um,
I think let's take this question first, I think, because it's related.
okay.
Does the penalty apply to Medicare as secondary payer payments too?
The PPS payment is actually the reduction. It's only to Medicare payments at this point in time. I've been avoiding it, but I should mention it, and I don't know if there are any questions on it, but I think it's no surprise if you're following Medicare Advantage actually covers a greater percentage of patients on dialysis than traditional fee-for-service Medicare. Right now, the PPS actually applies to Medicare. Uh, there is some movement afoot, so we may or may not see that change. Again, I have no inside track. I don't know, but right now it is just to Medicare. This is why commercial has been such a saving grace, and is a lifeline for many facilities. Excuse me. Monthly capitated payment, did you want me to?
Yeah, I mean, there has not been like a drastic change on that front, though, compared to the PPS side, right?
Yes. Now, this actually, I can tell you, goes back to, and actually, I think probably the one that I associate most with driving this was Chuck Grassley, Senator Grassley, going back many, many, many years. Initially, there was actually a single payment, and then to try to encourage more frequent visits, it was changed to a payment for one visit a month, 2 to 3 visit a month, and 4 visits. And then home obviously had to be added to that. But yes, there has been less of a change on that, as you all are, well, you may not be aware. Keep thinking of Rob Blazer, who I get so much of this from Renal Physicians Association. But there has been a movement toward shifting reimbursement for all physicians from concentrating on hospital care to outpatient care. So nephrology overall did end up with a slight positive benefit. I think Rob said ultimately about a 1%. But so yes, there have been small changes in the MCP due to general Medicare each year. But given the current focus of CMS, maybe for this year and years to follow, we will see some increased focus on that to try to encourage that. This is not, again, exclusively focused on nephrology. This is all specialties.
Mhm. Okay. Thank you. Any other questions?
I know there were a bunch in the chat, so, but okay.
So I just found
Yeah.
out that Dave, Dr. Henner has been selected to serve on Dialysis Facility Quality of Patient Care Star Rating Technical Expert Panel, so TEP. So that's amazing. Congratulations, Dave.
Yeah, wonderful, Dave, for
Yeah,
you and for the forum.
absolutely. So that's amazing. Okay. So if there are
Yeah.
no further questions, I want to thank Dr. Howard for an excellent talk and taking questions from our participants. And many thanks to all our participants for joining us. And we hope that you join our next webinar. This is going to be on the 18th of February at 3 p.m. Central Time or 4 p.m. Eastern Time. The topic is physician leadership and governance in dialysis units. And Dr. Cam Kalantar-Zadeh will be the speaker. So I hope you will all join us, and we hope to see most of you, all of you there. Take care. Thank you.
Thank you, everyone. Thank you for the privilege of speaking.
Thank you so much, Andy. Bye.